Thank you very much for that very kind introduction. It's a great pleasure to be here. And thanks definitely to Ravi, who's been a great supporter of mine over the years. It's really nice to see you again, and especially in India. So it's my task today to talk about the composition of fluid during CRRT. What is the role of the solutions that we have in the machine? How do they mimic kidney function? And how can we optimize the treatment of our patient by understanding the composition of fluids? Well, what do we do when we're doing some form of renal or kidney replacement therapy in the ICU? Well, we're trying to do some form of blood cleaning. We're trying to regulate plasma constituents, and we're trying to remove fluid. By fluid, what we really mean is water with electrolytes at their normal physiological concentration in it to remove bulk volume for our patients. Now, the first two we can utilize either diffusion or convection within our extracorporeal circuit. The last of these requires ultrafiltration in order to, i.e. convection without replacement, in order to achieve it. And when we've got to think back is what the kidney itself does, and obviously the kidney has a filter, but the kidney has a tubular system, and the tubular system is extremely complex, as you'll appreciate, and is capable of modifying the ultrafiltrate dramatically in order to achieve the goals of homeostasis. And so the sort of father of the concepts of modern kidney homeostasis, Homer Smith, made the statement the composition of the blood is not determined by what the mouth ingests, but by what the kidneys keep. Well, I'm going to tell you that the fluid composition of the replacement or dialysis fluid really provides a surrogate of tubular function when we're talking about kidney replacement therapy. And therefore, to some extent, our patients in the intensive care unit, the composition of their blood and other body fluids is determined by the composition of your solutions. So a generic CRRT circuit obviously has room for a number of different solutions in a number of different conformations and can perform continuous dialysis, ultrafiltration with replacement in order to perform hemofiltration in pre or post dilution, and obviously to combine these therapies. And as you heard earlier, the overall flow of effluent is an approximation of dose, allowing for the various factors that can modify that, including pre-dilution and some of the performance characteristics of the circuit that can compromise that. So what happens in dialysis? Well, dialysis requires a solvent to be present on each side of the semipermeable membrane to allow diffusion to happen in solution. And the speed of diffusion is going to be determined by the gradient across the membrane. Molecules will move freely under the thermodynamic effects of temperature, but if there are equal concentrations of sodium on each side of the membrane, then movement will be equal in both directions. There'll be no net movement, whereas if there is only potassium on one side of the membrane and not the other, you will optimize the flow of potassium across the membrane, and this is, of course, is why we then continuously replace the dialysate and use a countercurrent flow to optimize the concentration gradients for the things that we want. But of course, you can see that if we do not want to remove potassium, if our potassium is normal or low, then we will add potassium to our dialysate. We will affect the removal of potassium across the membrane, but we would not affect the removal of, say, urea, which we may wish to clear. So in this setting, we're removing potassium and urea across the membrane, and of course we have a higher bicarbonate concentration on the other side, and so in fact we're donating bicarbonate back to the patient. Hemofiltration, we have a substitution fluid, very, very similar in composition to the dialysis fluid, but what this is doing is it's able to counteract the fact that in order to get an adequate level of clearance to actually achieve some solute clearance that's meaningful to the patient clinically, we would need to dehydrate the patient by 1 or 2 liters an hour, which would rapidly cause hemodynamic collapse. And so we have to provide a substitution fluid, but in fact the substitution transfusion fluid plays a vital role, because in fact we want to only remove some things and not others, and so we can fine-tune the net movement of solute out of the patient by altering the composition of the substitution fluid. So again, by comparing the composition of potassium within the blood versus that in the substitution fluid, we may be at the point where we're removing potassium or in fact donating it back to the patient. And similarly, we will be largely donating back bicarbonate. We obviously need to replace the bicarbonate that we have filtered, which is important, otherwise we will deplete our buffer, but then we actually want to replenish the buffer that may have been depleted by the effects of illness. And so this is the way in which a convection modality would achieve the solute homeostasis. Of course, we can combine the two in hemodiafiltration and use the same fluids to do the same things within the same circuit. So if we're talking about regularization of fluid composition, well, obviously our final goals, as long as the molecules are sufficiently small to actually cross the membrane, will be determined by the composition of the replacement fluid. But the rate of change in plasma composition is going to be determined by many factors that determine dose and obviously the initial gradient. So when we look at these bicarbonate buffered CRRT solutions, which is what we tend to use, at least in the UK as our standard solutions, you can see that they largely represent the homeostasis that we want to achieve. But not for everything. For instance, most conventional solutions do not have phosphate in them. Clearly we may want to regulate rather than just remove all the phosphate from our patients, and we therefore have to consider that. Potassium is variable, but most other things are not variable in these standardized solutions. I would also point out that if we look at the fluid that we're giving, it's actually not quite what you might expect. For instance, the chloride is rather higher than you might expect, given that we're wishing to regulate chloride and not make our patients acidotic. And this actually reflects the fact that we're not actually dialyzing or filtering against plasma. We're dialyzing and filtering against the plasma water. That's what is actually in solution. And the plasma water concentrations are different because they are in a smaller volume than the total plasma volume, which includes the plasma proteins. And so it's the plasma water concentrations we're acting against in the aqueous solutions. These are rather higher, and the reason we report the plasma concentrations is because that's what will happen when flame photometers were used to measure iron concentrations in plasma, and it's carried over in the 40 years since those were largely discarded. So then that kind of fits for the chloride, but then you kind of wonder why the sodium isn't a bit higher. And that is because the sodium, it will tend to be retained by what's called the Gibbs-Dolan effect, the fact that albumin is negatively charged and will not cross the membrane, and therefore we will tend to slightly retard the clearance of sodium across the membrane and actually slightly promote the clearance of chloride across the membrane. And so this effect actually kind of has the net effect that actually the sodium concentration in our replacement solution is rather similar to the plasma concentration in total, but the chloride concentration needs to be a bit higher because the chloride concentration both has a slightly higher sieving coefficient and a higher plasma water concentration. So that's a few kind of tidbits about the composition of fluids. Let's talk in the latter half of this talk about some practicalities. So we'll go through a couple of brief cases. The first one is a case looking at acidosis. This is a 22-year-old male who presents very sick with acute leukemia and unfortunately the very high mortality condition of hemophagocytic lymphohistiocytosis. He has got severe lung injury with a very high FiO2, and he has a severe lactic acidosis, coagulopathy and thrombocytopenia, and he's on a moderate dose of noradrenaline. He's certainly acidotic with a mixed acidosis from respiratory acidosis due to his lung protective ventilation and his elevated serum lactate. And he's in renal failure, he is anuric, and he has potassium approaching 6. So he clearly needs CRRT. How can we use CRT to improve its clinical condition? What's the main benefit? Fluid balance control, lactate removal, donation of bicarbonate, cytokine removal, we've heard discussed, potassium and phosphate control. Many of these may or may not be true, but let's concentrate on acid base in this situation. It's important to remember that the vast majority of the acid produced by the body is excreted by the lungs. So 20,000 millimoles of carbon dioxide are produced per day. We only excrete 80 millimoles of organic acids through the kidneys. So the kidney is not the main excreter of acid, but it's the main regulator of pH. And just to illustrate here, we're not removing acid in CRRT by removing hydrogen ions dissolved in solution through dialysis or convective clearance. The concentration of hydrogen ions in solution is tiny, they are buffered. Okay, we would need to clear a million litres a day to remove, to regulate acid base by removing hydrogen ions. CRRT controls acid base by restoring plasma buffer, i.e. by bicarbonate donation. And that's exactly what the kidney does as well. Our lungs can breathe off CO2, but CO2 dissolved in water has a pH of 4.5. Even the pKa of the CO2 buffer, if you equilibrate it, is 6.1. The kidney needs to excrete a lot of hydrogen ions in the form of ammonium chloride and generate bicarbonate in order to create the correct pH of the blood buffer. So this is what the kidney is doing. It's not necessarily excreting the majority of acid, but it is maintaining the physiological pH that we need for our proteins to work, and that indeed is what we are doing with our CRT devices. So what about removal of lactate? Well, there are a number of people who have looked at this. The fact is that we've got to think about what the normal lactate clearance is and how it is removed. The kidneys metabolize lactate, but they clear very little by ultrafiltration. The main source of lactate clearance in the body is the liver. The liver clears about 1 litre of lactate a minute. So what you will only find is that lactate concentration by CRRT, which will be vastly smaller than 1 litre a minute, even with a very high dose, is only going to be really meaningful if the lactate concentration is extremely high and the liver function is extremely poor. And so really, we're never clearing lactate significantly in a CRRT device. If the lactate gets better, it's because your patient's getting better. Now, maybe your patient's getting better because you've controlled the pH, your vasopressors have come down, and other things, but it's not actually removing lactate. So the role of CR in this case is to resolve the metabolic component of acidosis, manage fluid balance, and improve respiratory mechanics, and prevent worsening hyperkalemia and hyperphosphatemia, particularly in the context of tumor lysis as the patient is treated, which would be a really significant clinical challenge. So I think we've got time to discuss another case. So this will be a man who's suffered polytrauma. He's been through the mill of interventional radiology and multiple laparotomies. He's developed pelvic sepsis through a rectal injury. He has a defunctioning stoma, a long period of mechanical ventilation, tracheostomy. He develops extensive muscle loss, both directly as a result of the embolization and indirectly as a result of prolonged critical illness. He has a nosocomial pneumonia during his stay, a prolonged period of AKI, a slow ventilatory wean. Every morning he has a phosphate that's pretty low. He's on continuous CVHDF, as we did at that time, continuously. His renal numbers look suspiciously good despite the fact he's anuric, and they reflect really for his creatinine the massive loss of muscle mass. His creatinine for that dose of CRRT as a kind of quasi-GFR should be about 2 to 3 times that if he had normal muscle mass. He's hemodynamically stable, he's needing phosphate 40 millimoles a day. So low phosphate, what should we do? Should we increase phosphate, reduce the CRRT dose, give a semi-intermittent therapy, use a phosphate-containing replacement fluid? All of these are possible, okay, but the key factor is, why is the phosphate requirement so high? Is this because of the CRRT, the dose of 25 mils per kilogram per hour, or is this refeeding? Well, what we've got to remember is that phosphate is not handled by the kidney, just by the glomerulus. It undergoes extensive tubular resorption. So your normal renal phosphate clearance is only 5-10 milliliters a minute. CRRT, our tubules for CRRT don't have any phosphate in the replacement solution normally. So we've got no effective tubular function in CRRT. So in fact, we may be giving more than double the normal phosphate clearance with CRRT, despite the fact we're only giving a fifth of the normal creatinine clearance. And so this explains why the patients need large amounts of phosphate. This is not true in intermittent dialysis because phosphate is predominantly intracellularly and its clearance will be rapidly attenuated during a short session because it's not in equilibrium. But CRRT is in equilibrium. So what do we do? Give exogenous phosphate, reduce the dose, add phosphate to the replacement dialysis fluid. Well, certainly we can use phosphate-containing solutions, and they're very attractive, particularly in combination with citrate. But you may also be wanting to do rehabilitation in this patient, and maybe a semi-intermittent therapy would be an appropriate choice for them at this stage in their illness. So a bit of time for a final case. This is a 55-year-old man with a history of ischemic heart disease and diabetes, who develops ascending cholangitis. He is aggressively fluid resuscitated, ends up ventilated, probably peri a procedure, but then cannot be extubated. He's sedated, he's on multiple antibiotics, he's growing Klebsiella in his blood. And now he's developed a significant noradrenaline requirement. He's actually got lung injury and fluid overload, and he's on 60% oxygen. His cardiac index is barely adequate, reflecting his poor baseline cardiac status, and he's anuric now. And the question is, how should we manage him? I think that most people would agree that we probably should try and remove fluid. He's strongly positive fluid balance. He has got adverse effects of fluid overload in terms certainly of a high oxygen requirement and potentially due to relatively high intra-abdominal pressure. What goals do we set? Are we really just targeting fluid balance? Do we need to set goals for his hemodynamics, or are we looking for goals of other organ function? It's undoubtedly true that if you have a requirement for renal replacement therapy in the ICU, if you're not fluid overloaded, you have a better outcome than if you are fluid overloaded. And this is a linear association, as nicely shown here in the AKI study. Now, obviously, patients who are fluid overloaded are different. They've come there a different route to patients who are not fluid overloaded. But you could probably argue that they would not at least benefit from continuing to become more fluid overloaded. Similarly, in the renal study, which, as you're aware, was a dosing study, they did a secondary analysis looking at fluid removal, and patients who were able to achieve fluid removal had better survival. But of course, that presupposes the patients were hemodynamically stable enough to achieve the fluid removal, and so it's difficult to determine the direction of causation. But again, I think the aim is to try and remove fluid, but the question is how easily we can achieve that. So we've got to think about our goals. Our real goals are to resolve fluid overload and its adverse effects on organ function, allow necessary therapy which involves giving fluid to our patients, but to prevent intravascular hypovolemia, secondary ischemic injury, and other adverse neuroendocrine responses, and to avoid complications of RRT. And so there are decisions to be made in describing ultrafiltration, and again, this is the long-term goal and the short-term tolerance of fluid removal. And I'm going to touch on this a little bit more in a talk I'm giving tomorrow about lung injury and the interaction between acute kidney injury and lung injury and how we can best treat patients. And so I think that it is best to reserve some of that for the discussion tomorrow, and perhaps just to move forward to some conclusions, which are that with regard to fluid overload, that fluid overload is a common occurrence in the critically ill and it's strongly linked to adverse outcomes. It's possible that limiting or resolving fluid overload might require early recourse to RRT if patients have got acute kidney injury and are fluid overloaded. But prescribing fluid removal requires attention to the total fluid excess, but also at the rate of vascular refilling you're going to be able to achieve in the hemodynamic stability of the patient and their ability to tolerate perhaps the obligate small amount of intravascular hypovolemia that one requires to remove fluid when you're removing it from the blood, but the fluid overload is mainly in the tissues. And so we're going to have to individualize treatment and reassess responses frequently, because probably regulation of electrolytes with renal replacement therapy and acid base is relatively easy, but regulation of fluid overload is extremely hard because of the fact that we're removing it from the circulation where we actually need it, and not from the tissues where we don't want it, and we have to rely on this sort of indirect refilling of the plasma that can be highly unpredictable. So it's important to remember that CRRT is like a drug, and it requires careful thought and prescription. Unfortunately, these old pills weren't very effective for kidneys. In fact, they were mostly primitive forms of non-steroidals that were probably worse for your kidneys. But nevertheless, we've got to make sure that we use CRRT in a way that is good for our patient and not bad for our kidneys. Thank you very much.